Welcome to Diabetes Core Update, the American Diabetes Association's official monthly podcast. We have another excellent issue this month, beginning with an article from the New England Journal of Medicine titled Semaglutide and Cardiovascular Outcomes in Obesity Without Diabetes, the SELECT trial, really a landmark trial where we'll be talking to one of the authors of the study, Dr. Robert Kushner. Then, we'll discuss an article on the economic costs of diabetes in the United States in 2022, published in Diabetes Care, followed by a discussion of an interesting article on intensive lifestyle intervention for remission of early type 2 diabetes in primary care, the DIRECT-AUS study, published in Diabetes Care, and then another article from Diabetes Care on the efficacy and safety of CGM in patients with type 2 diabetes. This is a systematic review and meta-analysis of interventional evidence. Finally, an article published in the journal Circulation, which is a presidential advisory from the American Heart Association on cardiovascular, kidney, metabolic health, where we'll be talking to the first author, Dr. Chiadi Ndumele. Our first article this month is from the New England Journal of Medicine titled Semaglutide and Cardiovascular Outcomes in Obesity Without Diabetes, the SELECT trial. Joining us today is Robert Kushner. Dr. Kushner is a professor of medicine in the Feinberg School of Medicine at Northwestern, and he has written more on obesity-related things than I think most of us have read. Welcome, Bob.
Thank you, Neil. It's a pleasure to be here with you.
This is an incredibly exciting time in the area of weight management, and this is an amazing article. Can you give us some insight into the background of why the study was performed?
Sure. I think it's going to go down as a landmark study regarding obesity. Up until now, there's been multiple secondary outcome cardiovascular trials in patients with diabetes who happen to be overweight or have obesity. This is the very first trial to test the effect of a GLP-1 receptor agonist, semaglutide, in individuals living with obesity or overweight without type 2 diabetes. And that's really why it's a landmark study.
So this is pretty amazing. Briefly, the methodology.
Sure. So it was conducted around the world in 800 clinical sites in 41 countries, and individuals, 17,000 individuals with overweight or obesity without diabetes were randomized 1-to-1 to either semaglutide up to 2.4 milligrams weekly injection if tolerated at that dose, or placebo. To get into the study, participants had to be 45 years or older, or a BMI 27 or more, with established cardiovascular disease. So that was either previous MI, which was 2/3 of the individuals met that criteria, previous stroke, about 18% had that, or symptomatic peripheral arterial disease. So those are the three that they were looking at. And I want to point out something also very important, is that all of these individuals were we would call good cardiovascular treatment. They 90% were receiving lipid-lowering medication, 87% lipid aggregation inhibitors, 70% beta blockers, and so forth. So these are individuals under good care around the country. The only difference was whether they received an additional treatment of semaglutide, 2.4 milligrams, or placebo.
Yeah, and that setup makes it, in some ways, really hard to show an effect, because when you have people that are treated well, you're really carving out the issue of residual risk, which we've always been trying to go after, and currently is harder to show a benefit than it was, say, 30 years ago when our treatments weren't as good. Is that correct?
That's exactly right. And that's you nailed it. What we're going after is that despite the maximal or good cardiovascular pharmacologic treatment, you still have residual risk. So it turned out after about 3 years of observation The placebo group had a 8% event rate, and we estimated 2% per year. So it was even a little bit higher than we thought after 3 years. In the semaglutide group, it was 6.5% event rate, and that's where you get the hazard ratio of 0.8 or 20% reduction.
Now, that's an impressive reduction in MACE, which, of course, is the composite endpoint of death from cardiovascular causes, non-fatal MI, and non-fatal stroke.
And I realize it was statistically significant, but what was the p-value? Because I think our listeners want to know, did it just make it, or was this a p-value that was pretty darn clear that the effect was real?
0.001. So that's pretty good.
That's pretty amazing. So, so the effect that we're seeing is a real one. Can you tell us about, the effect on MACE, and I know in some of the SGLT2 trials, we saw a MACE effect, but we saw it in, for instance, in MI, in cardiac death, but we didn't see it in stroke, the other part of 3-point MACE. Here, was it across all of the parts of the 3-point MACE?
Yeah, I'm glad you brought that up. Probably the best comparator is SUSTAIN-6, which was semaglutide in individuals with diabetes. In that case, MACE was 20% reduction, and here we got a 20% versus 26%. The big difference, and it's actually led to a lot of questions, in SUSTAIN-6, which is diabetes, the reduction in non-fatal stroke was 39%. I mean, incredibly impressive. In this study, the effect on stroke was much less. It was only 7% and did not reach, and would not have been statistically significant because the confidence interval went above 1. This was a completely different group. It was not a group with type 2 diabetes, and only 18% of individuals got into the study because of a previous stroke. So it's a different population. It's hard to tell. I can tell you though, Neil, if we look at all of these secondary confirmatory endpoints beyond MACE, they were all in the right direction, although they did not all meet, a good p-value that we would look at.
Yeah, and it's important for our listeners to realize when we start looking at subgroup analyses and different endpoints, we wouldn't expect them all to meet statistical significance because there often just are not enough people in those subgroups. But what we really do look for is consistency, that all of the endpoints are in the right direction, as you said. Bob, can you also talk about some of the other secondary endpoints, the effects on other metabolic parameters?
Yeah, so we did see, again, despite optimal treatment, as I said, with all these other pharmacologic agents, we also saw improvements in lipids. We saw improvement in glycemic control, which is actually the most interesting one. Let me pause there a moment to tell you that 2/3 of the individuals had prediabetes. None of them had diabetes, but if we look at the threshold of prediabetes of greater than 5.7% or more, 2/3 of individuals had that. We saw profound improvement in glycemic control. And further analyses will look at different levels of hemoglobin A1C and so forth. Improvement in triglycerides, improvement in blood pressure, and a significant improvement in C-reactive protein. And that improvement in C-reactive protein really highlights another important point I want to make. And that is, if you look at the separation of the curves regarding mortality or the 3-point MACE, it starts to separate very early, actually during a time when there's still a dose escalation of the semaglutide, suggesting a weight-independent effect in this study.
Pretty amazing results. So what do you see as the clinical implications of these results?
I think it puts the focus on obesity right up front. The American Heart Association just floated a new idea of cardiovascular kidney metabolic syndrome. And if the staging system of the new AHA recommendation, stage 1 is dysfunctional fat and obesity. So I think it's highlighting very clearly that part of that residual benefit or risk, as you mentioned earlier, is coming perhaps from effects of obesity, inflammation, other areas that a GLP-1 receptor agonist targets. And we as clinicians now need to look at our patient who comes into the clinic with heart disease or sleep apnea or diabetes or dysglycemia. and really look at their weight as an independent target that we need to be thinking about on that visit.
Yeah, and the epidemiology would suggest that separate from its effects on glycemia and hypertension and lipids, that weight, when tracked, is related to cardiovascular outcomes.
Yeah, we know that. We know either a 10-year risk of developing atherosclerotic disease or lifetime risk. It is
Yeah.
segregated by BMI, poor marker of obesity, but that's what we look for in population studies.
Right. And this trial really shows that we have a very real effect in a high risk group on the important outcome of 3-point MACE. Now, I'll ask you one last question. When we looked at the evolution of knowledge in diabetes, early on, we saw in the LEADER trial, the SUSTAIN trial, and others, an effect on MACE in very high-risk groups. The initial trial was just like this one in people who had primarily enrolled with existent vascular disease. And it wasn't until later, I believe it was the REWIND trial, that had a large proportion of the patients who also had risk factors but not established disease. Do you think we're ever going to see a trial looking at people with and without cardiovascular disease in the treatment of obesity?
Well, I think we will. I mean, I don't want to go beyond my skis, as we say, stick to the data. These are individuals with existing cardiovascular disease. Now, I'll also tell you that tirzepatide also has an ongoing trial, results coming up in a few years, looking at the same kinds of outcomes. We'll have to see, but without going beyond the data, there's enough to work with here. How many of us do we see patients in our office who have elevated body mass index or excess body weight, have risk, have existing cardiovascular disease? There's enough patients right there we need to turn our attention to, really starting right now.
Bob, this was so helpful, and what a great overview, and what important information for all of us. Thank you so much.
Thank you, Neil.
Our next article is on the economic costs of diabetes in the U.S. in 2022. This study updates previous estimates that we've talked about on this podcast of the economic burden of diagnosed diabetes with calculations of the healthcare resource use and indirect costs attributable to diabetes. The data sources were large and broad, including national surveys, Medicare analytic files, and administrative claims data. The total estimated cost of diagnosed diabetes in the United States in 2022 was $412 billion, including $306 billion in direct medical costs and $106 billion in indirect costs attributable to diabetes. Care for people diagnosed with diabetes accounts for 1 in 4 healthcare dollars in the United States. On the average, people with diabetes incur annual medical expenditures of $19,736, of which approximately $12,000 is attributable to diabetes. People diagnosed with diabetes on the average have medical expenditures that are 2.6 times higher than what would be expected without diabetes. Glucose-lowering medications and diabetes supplies account for approximately 17% of the total direct medical costs attributable to diabetes. John?
So, Neil, this always boggles the mind anytime we talk about some of these economic burdens. So if you talk that roughly $1 out of $4 spent in healthcare is spent on a patient who has diabetes, and $1 out of $5 in the U.S. economy is spent on healthcare, $1 in $20 in the U.S. economy is spent on the care of someone with diabetes. And you don't see these numbers going down. And, you and I have talked about that this is a certain kind of renaissance. There are so many great medicines now for taking care of diabetes, but none of them are cheap. So, one of the things is perhaps by using these better medicines, we can avoid a lot of the complications. So if you break down the study, 50% of the money that's spent on vascular surgery in the United States is spent on the care of a patient who has diabetes. About $1 in $3 that are spent on nephrology in the United States are spent on patients with diabetes. So maybe if we can use some of these better tools, that we can avoid some of these long-term macrovascular, microvascular complications. But, if you were really looking at this like a business person, you would say there was all these people out there who are potentially going to become a patient with diabetes. And can we really sink a lot of money into the diabetes that never happens? Perhaps we need to look at the economics of a cure much more than the economics of treatment.
Before we go on to our next article, I want to share with our listeners, John, a time-limited opportunity to join the American Diabetes Association. The ADA is currently extending a special offer for new members. When you sign up for a new professional membership at the ADA, use the code NEW24 during checkout. You'll get 25% off the yearly membership price for your first year. You'll also get exclusive discounts on ADA's scientific sessions and other meetings. You'll get a subscription to one of ADA's journals, such as Diabetes Care, Diabetes Spectrum, or Diabetes, a copy of ADA's Standards of Care in Diabetes, as well as other member-exclusive discounts, continuing education opportunities, and access to all sorts of webinars. There is a lot of value here. Remember, though, that this offer is for new members. Go to professional.diabetes.org/membership, create your account, fill out the application, and remember to use the discount code NEW24 at your checkout. Also remember, this offer expires March 31st, 2024.
So our next article is from Diabetes Care, and it looked at intensive weight management using a low-energy total diet replacement for achieving remission of type 2 diabetes in an Australian primary care setting. So in this particular study, they had patients who were recently diagnosed with type 2 diabetes who had a BMI greater than 27 from 25 primary care practices in the Australian region of New South Wales. They started a 13-week low-energy total diet replacement with Optifast. Then they moved on to an 8-week structured food reintroduction and a 31-week supported weight management. And glucose-lowering medicine was withdrawn. What they found is that diabetes remission occurred in 56% of the participants with a mean adjusted weight loss of 8.1% at 12 months. The likelihood of diabetes remission was proportional to the amount of weight loss that the patients had. So this is a really exciting thing about potentially what I just mentioned is preventing diabetes or curing diabetes. Neil?
John, when I read the title of this article, I was incredibly excited. And I was excited when I read the results. But boy, oh boy, when I read the methodology, I have to say, I'm overwhelmed by how difficult this was. And let me just discuss a little bit of what the patients had to do who enrolled here before discussing the outcomes. So they underwent a 13-week total dietary replacement, as you mentioned, with Optifast, with every other week dietitian visits. The goal was to give them 800 calories a day. That is not many calories. They were encouraged to consume at least 2 liters of water and 2 cups of low-starch vegetables with a teaspoon of oil daily. And then they had individual prescriptions to prevent weight regain. They had monthly visits with the dietitian. And if they began gaining weight, they were monitored regularly. They were put back on different levels of low-calorie diet. If they gained more than 4 kilos, they were put back on their 800 calorie a day, low complete dietary replacement for 4 weeks. This is really hard. I mean, the outcomes were impressive, but I'm not sure how many people could actually follow this rigorous of a program, nor am I sure how long they could follow for. You know, one of the things that was interesting, I've always said, and and our listeners know, I am a strong believer in diet and exercise, and it's so safe. Well, under this program, there actually were 2 serious adverse events among those enrolled that were felt to be related to the study. Both were for hypotension. One case involved someone also had hypoglycemia and required reductions in medicine as well as antihypertensive agents. There are other studies out there that have used intensive lifestyle therapy that have shown diabetes remission. It is an important test of concept. I'm not sure how easily this could be implemented in the real world. Our next article from Diabetes Care is on the efficacy and safety of continuous and intermittently scanned continuous glucose monitoring in patients with type 2 diabetes. This was a systematic review and a meta-analysis. What the authors' goal was to assess the benefits and potential harms of CGM and intermittently scanned CGM compared to usual care or self-monitoring of blood glucose in individuals with type 2 diabetes. They conducted a comprehensive search of Medline, Embase, and the Cochrane Library, as well as other resources, and they analyzed the studies that included those that were randomized controlled trials that compared at least 2 interventions for more than or equal to 8 weeks in a population of people with type 2 diabetes that included CGM in real time or a retrospective mode, short and long-term CGM, intermittently scanned CGM, and self-monitoring of blood glucose. What they found was 26 randomized controlled trials involving over 2,700 patients looking at CGM versus usual care with or without self-monitoring of blood glucose. What they found was CGM reduced A1C by 0.19%. They had something called a glycemic medication effect score, meaning were you able to either take off glycemic medicines or add less of them. That was negative 0.67, which was good. They had surprisingly reduced user satisfaction and an increased risk of adverse events by about 20%. The intermittently scanned CGM also reduced A1C, here by 0.31%. There was increased user satisfaction, and there also was an increased risk of adverse events. John?
So Neil, I found this a curious article, and I think the bottom line is the people who use CGM did better than the people who did self-monitoring of blood glucose. And I think one of the problems with doing a big research analysis of a topic is it's going to have some historical findings. If I was doing a literature research on televisions, and I looked back at the last 20 years of televisions, some of the articles from TVs from 15, 20 years ago really don't speak to the televisions that people have in their homes right now. And I think some of the curious data that came out of CGMs were older studies when CGMs weren't quite as user-friendly as they are today. So I probably wouldn't get too lost in the weeds. I think, the intermittent scanning, I think people would rather have a little bit of control over when they're going to see their sugar as opposed to just getting lots of beeps and things going off a little bit more continuously. So I do see that as something that, for patients to have a little control if they have a CGM when they are seeing their data and that they're not bombarded with their data all the time. But I find some of the results besides the overall A1C lowering and satisfaction to be curious, and I probably wouldn't put too much validity to that.
For our final article of this month's podcast, we are featuring an article from the journal Circulation that is titled Cardiovascular, Kidney, Metabolic Health, a presidential advisory from the American Heart Association, a critically important concept for us to become aware of. To discuss this article is the first author of the article, Dr. Chiade Ndumele. Dr. Ndumele is an associate professor of medicine and a general and preventive cardiologist at Johns Hopkins University. His research focuses on the relationship between obesity and cardiovascular disease, particularly heart failure. Chiade, welcome to our podcast.
Thank you so much for having me.
To start out, can you share with us some background on this to help us understand the need for this concept? This is a little bit reminiscent, more than a little bit, of metabolic syndrome, but it seems to go further.
Yeah, that's really true, and there's certainly some overlap, but it is a step beyond. This is a matter of major public health urgency because CKM, cardiovascular kidney metabolic health, or cardiovascular kidney metabolic syndrome, reflects the fact that there's this close interplay among metabolic risk factors, obesity, diabetes, and metabolic syndrome, chronic kidney disease, and the cardiovascular system. And that when we see this interaction, we see a lot of damage to a lot of organ systems, some multi-organ dysfunction, and we also see premature morbidity and premature mortality. So this has led to an interest in better defining this syndrome and understanding the unique challenges that are leading to the bad outcomes in this population. I'll also just mention that CKM syndrome is disproportionately prevalent where there are more adverse social determinants of health. So it's a key contributor to disparities in the population. And another very key challenge when people have multiple conditions is fragmented care. So we're really interested in multiple providers being on the same wavelength and providing more holistic care for our patient population.
I was really struck by that aspect of it. Those of us in primary care take care of people who have many diseases, and increasingly over time we've lived in a system of specialization and subspecialization that becomes challenging for patients as well as us. And I have to say, I loved the way this had a holistic, a biopsychosocial approach, including social determinants of health. Can you define cardiovascular kidney metabolic syndrome for us?
So cardiovascular kidney metabolic syndrome is quite simply most easily defined as a health disorder that results from the connections among obesity, diabetes, chronic kidney disease, and the cardiovascular system. It includes individuals who are at risk for cardiovascular disease as a consequence of metabolic risk factors or chronic kidney disease. It also includes people with existing cardiovascular disease where the presence of metabolic risk factors or chronic kidney disease should influence approaches to management. So that's the simplest definition for considering that.
That's great. And to help us operationalize it, the committee divided it into stages. Can you tell us about the stages?
Yeah, so the stages of cardiovascular kidney metabolic syndrome were really meant to emphasize a life course approach to prevention. So cardiovascular kidney metabolic syndrome most commonly starts with excess or dysfunctional adiposity. So we have actually a stage 0, that's individuals who have none of these CKM risk factors. And that's really where we want to focus on primordial prevention. That's where we hope most people will stay for as long as possible. Stage 1 is where we start getting to excess or dysfunctional adiposity. That's elevated BMI, elevated waist circumference, which is really closely linked to a lot of these metabolic risk factors, or even in the absence of that, having dysfunctional adipose tissue as reflected by impaired glucose tolerance. Then that is really the gateway that most of the time leads to stage 2, which is the development of these overt metabolic risk factors or moderate to high risk chronic kidney disease, which of course most commonly is secondary to metabolic risk factors. That leads to stage 3, which is subclinical cardiovascular disease. But to be clear, we're not advocating for population-wide screening for subclinical disease. So we also have risk equivalence there as well, which is individuals who have very high risk CKD as defined by the KDIGO KDIGO classification, or very high predicted risk using the new AHA CVD risk calculator called PREVENT. And then stage 4 is individuals who have actually existing cardiovascular disease that overlaps with those pre-existing metabolic risk factors and or chronic kidney disease. And the goal, this is for both youth and adults, is to prioritize prevention across the life course. Each of these places are windows for prevention, and to also lead to earlier detection of risk, but also to support the concept of regression, because with significant weight loss and lifestyle change, we can actually often see regression in some of these CKM stages over time as well.
Fantastic. That now makes so much sense. We won't have time to go over all the different aspects of treatment which are covered in the presidential advisory, but can you give us a sense in general of how you see this concept being used or operationalized by practitioners?
Yeah, that's really helpful. So I'll mention 3 major areas. So number 1, in order to put people in the stages, we needed to do some screening as well, so that we can basically put asymptomatic individuals in the appropriate stage. So some of that will require screening. The screening intensity is related to the intensity, and the frequency is related to the CKM stage. But once we get there, I will say that the CKM stages not only represent the pathophysiologic progression of CKM syndrome, they also represent the absolute risk for cardiovascular disease, kidney failure, mortality, other outcomes. So the intensity of our interventions is going to increase as we go along into further CKM stages. The other piece that I want to emphasize is that we have a lot of these new therapies, in addition to the things that we know about, like lifestyle change, basic risk factor control. We have all these newer therapies like SGLT2 inhibitors, GLP-1 receptor agonists, finerenone, that all have a really great impact on metabolic, kidney factors, or on cardiovascular disease. So we give a framework for how to think about those therapies. The other thing that I'll mention is that for people who have a confluence of these factors, we emphasize approaches to interdisciplinary care and bringing together different providers, helping patients with navigating across multiple providers, because we want to provide that holistic care for patients. And the last thing, I think I'm saying 4 instead of 3, is social determinants, like you mentioned, is really key. So we actually want to be screening systematically for those and having individuals on our care team that can help with addressing social determinants of health as well when they're adverse and prevalent.
You know, you make it seem so logical and simple when I listen. I love the way that you describe them. We're almost out of time. Any other thoughts you have about this?
Well, I do think that, it's important to just to emphasize the fact that this was done as not just an academic exercise. This is something that we really want to think about how we're going to be applying to the patient population, because in the real world, it's not just patients with diabetes or patients with cardiovascular disease or patients with chronic kidney disease. Often it's the case that patients have all of these conditions. So how we best support these patients and prevent people from falling through the cracks, I think, is really key and really important. And I think that there's going to have to be some important changes to how we think about working together, think about reimbursements. And a lot of that is going to be part of the next steps for CKM Health. But we're really excited. The last thing I'll say is this was not something that cardiologists did. We worked with endocrinologists, nephrologists, adult physicians, pediatric physicians, primary care physicians, very importantly, nurses and pharmacists. It was really a multi-disciplinary approach that reflects the multidisciplinary nature of what we're trying to address. So really excited for everyone to come together to support CKM Health for our patients.
This makes so much sense. CKM Health, I can already see how I'm going to use the concept tomorrow in the office. Dr. Chiatti, Dumile, thank you so much for joining us.
Thank you so much for having me, Neil. Really appreciate the opportunity.
This was another great episode, and for our listeners, don't forget about ADA's special offer that we mentioned earlier for new members. There's a 25% discount for the first year. Go to professional.diabetes.org/membership, create your account, and use the discount code NEW24 at checkout. You need to act fast because the offer expires March 31st, 2024. For more information and links to the articles that we discussed in this issue, just go to www.diabetesjournals.org. Until next week, keep listening
and keep learning.